level.
George, let's talk a little bit about schedule. Gemcitabine, one of the most sensitive schedule-dependent drugs that we have out there. There was this small study looking at giving gem and nab-paclitaxel day 1, day 2. Talk a little bit about that.
Yeah, I think it's an interesting approach. We talked a while ago about the importance of the stroma and affecting the stroma. Some of the early preclinical data with nab-paclitaxel was that we were affecting the stroma. So by giving the drug a day before, nab-paclitaxel, and then following it up with gemcitabine, perhaps we're affecting that. So they did a trial of 150 patients, and they got good PFS, 5.8, overall survival, 10.1. So it wasn't harmful, but it does set, I think, a model for studying loosening up the stroma and then getting the chemo in there. Probably want better chemo than gemcitabine.
It doesn't look much different than...
Exactly.
It doesn't look any different. I don't know if I get to this conclusion. It doesn't look any different from any gemcitabine nab-paclitaxel study. In fact, I'd say it would argue against the primary premise that this is a stromal effect.
This is what oncologists do when they don't have new drugs, right?
10.1.
We had it on our biweekly...
Better than 8.5.
We had it on our biweekly study.
So we're not arguing necessarily to do this.
You can still do it on the biweekly. It's just
in fact,
it's a
Eileen's study,
exploratory study,
but I think Eileen, your study that was presented, I think not this ASCO GI, last ASCO GI,
10
had
months
a 10 months
for
gemcitabine
and we see that
nab-paclitaxel.
pretty reproducibly for
120
ECOG 0
patients.
to 1 in the US. And it's also going to be more cumbersome, so I personally have reservations.
Agree.
George, right back at you. So tell us about NALIRI and the role that it's played now, FDA approved, regimen with 5-FU in second line and beyond.
So NALIRI is obviously nanoparticle liposomal irinotecan. It's available, it's FDA approved, category 1 NCCN for second line or post-gemcitabine treatment. So very important. It allows us to have discussions with patients about, well, we start a first line therapy and now we have a second line therapy. Again, both FDA approved, both category 1 treatments. The study was done in Asia, partly 30% of the patients, the other 70% in the West. The dose was 70 milligram per meter squared combined with leucovorin, 5-FU, continuous infusion, no bolus. Toxicities were as expected, some neutropenia, a little bit of diarrhea. The neutropenia, it's very important to recognize, it was about 20% grade 3, grade 4, but 55% in the Asian population as opposed to 18% in the West. So it suggests that using this drug in Asian patients may lead to more toxicity, especially neutropenia, and that also may have affected the outcome. The survival benefit was 6.1 months, about a 2-month delta, and we're now using this regimen more and more. I think the research efforts are to bring NALIRI into FOLFIRINOX, a regimen called NAPOX, and that's going to be very interesting and really, again,
and that's in front line, I think that study.
That's in front line, and again, I'm going to, favorable pharmacology, and again, I'm going to say it may affect the stroma. So very important.
New drug. I'm gaining certainly more experience with this medicine. Anybody got any tips on managing this drug and when you might select it?
Yeah, I mean, it's first of all, going back to the issue of leucovorin briefly.
We got to let
very
go.
briefly. Very briefly, I will refer my friend from the great state of Florida to a study, and I'm happy to email it to you, that suggests that leucovorin adds more toxicity than benefit. So I'd like to avoid it altogether, period, if I can. The toxicities of nanoliposomal irinotecan are not much different than irinotecan, in all frankness. They're manageable. I mean, in centers like ours, even in community practices where there's large use of irinotecan, I mean, we know how to manage most of these toxicities, so it's quite manageable. The problem is, of course, the pancreas cancer patients tend to be sicker. We're used primarily to manage irinotecan in less sick patients with colorectal cancer. And so it's important to keep a close eye on those patients in the first couple of cycles. But overall, I think the toxicities are readily manageable.
I struggle with this issue of poor performance status in these patients. I mean, I was trained that if your low performance status is due to your cancer, that's not a time to back off on your treatment. That's in time to actually dial it up a bit. And, you know, but I still see lots and lots of folks giving single agent gem to people. And I have trouble justifying when I ever would do that. I mean, what you think?
Yeah, I think it's a complex issue, and very chemotherapy responsive diseases will accept a rapidly degrading performance status and give them the benefit of very intense cytotoxic treatments. I don't know that we do so well with that strategy in pancreas cancer, and I really do think we have to tailor therapies for those patients and sometimes lead in with single agents.
But if you don't even give them a chance at response.
I think if it's a very young, otherwise healthy person, yes, of course.
How old very young anymore?
It's all
Are you going to give me single agent gem? Is
all
that what
relative.
you're telling me?
Younger than 70. How about that?
So I really do. I struggle with this a
Yeah.
lot. Is that you know, the gem-nab regimen is really very easy and does not feel to me very different in toxicity from single agent gem.
So we have to be careful because for performance status of 2, and they've done this study, Hidalgo presented that data. And if you look at the PS2 patients, although there seems to be some little bit of activity, their median PFS was a little bit less than 2 months in the first line. So most of the overwhelming majority of these patients will progress, and their survival remains very poor. Now, I think it's important to acknowledge and understand that performance status measurement in pancreas cancer can be a little bit difficult. We have to first maximize symptom control as much as possible before
Absolutely.
calling a true performance status what it is.
I think that's very important. I think optimizing all the other ancillary issues to try to get them to the best level you can, and then to try to get the maximal therapy in initially for those that are on the decline.
I mean, there's clearly something humoral about this disease. The tumor burden doesn't go with how sick they feel, whether
Absolutely.
appetite or pain or all of those things.
So getting back to the poor performance status patients, there were patients in the MPACT trial that benefited. It was about a 1-month benefit. Of course, the outcomes are going to be affected by their performance status. That's pretty clear. But there is benefit from the doublet gem-Abraxane. And also in the second line, in the NALIRI trial, the Napoli study, also poor performance status patients were included. And so I think those patients are, it's reasonable to give them these treatments. I agree with you. Give the patient a chance, right?
Oh,
Don't
listen,
just send them to the hospital.
We're all for that.
No, give the
We're
patient
all
a
for
chance.
that.
Make sure you've optimized performance, all of that, and then see how they do with the chemo.
Yeah, but
you may have to attenuate. You may have to go to every 2 weeks. You know, but give the patient a chance.
So when you say give a patient a chance, there's also the chance of them having a good quality of life at the end of their lives.
Well,
and
this patient is going like
understood.
that.
So that's why we need to give them all their chances, not just a chance.
Yeah.
And that's
So
what
maybe
I
it's just a matter of seeing what the rate of their decline was as they came upon the
Well, I'm
diagnosis.
sure you have time, though. I
You
mean,
know,
those
someone
patients progress
who
quickly.
was really fit, you know, running, and then over the course of a couple weeks, within the time of their diagnosis, took a dive. That patient may benefit more from, you know, giving them a chance than someone who had a 6-month decline in their, you know, right.
I really think what we're hearing is that this is a complex matter, and you've got to, as you talk to your patients and understand how this disease is affecting them, and then make your best judgment call with the spectrum
You've
of
got to
tools that you've
communicate
got.
with the patient,
Yeah.
the family. This is a complex issue amongst us. So, yeah, a lot of work.